Respected teachers, senior ophthalmologists, my dear friends. So, I am Dr. Nivean and I'm going to talk about the new innovation, the CMT Flex IOL, a new option for aphakia. So, I do not have any financial interest. So, this first particular case, as you all know, because of the question why arose the need for a new IOL, because we already have the suture technique for more than 3 decades and various modifications of the technique. And then came Gabor Chariot, who introduced the haptics into the Chariot's tunnel and the glued IOL technique for more than a decade now, and various modifications of externalizing the haptic, the ethnic technique from the Arvind group, and the Yamane technique where they flange the IOLs. So let me go through the first case. As you can see here, it's a 360-degree subluxated lens which was planned for a lensectomy, vitrectomy with a secondary CMT Flex IOL. For any secondary T-Flex IOL, as you all know, the 0-180 degree is very important. So once the 0-180 degree was marked, we make a 2 by 2.5 millimeters partial thickness scleral flap using the crescent blade. As you can see here, a partial thickness flap is made. Then measuring 1.5 millimeters away from the limbus, a 23 gauge sclerostomy is done on both the sides. So here we have the lens to deal with also. I'm using the same sclerostomy sites. So using the 23 gauge cutter and just stabilizing the lens, making a puncture from the posterior part of the lens. Since it was a very soft cataract, a combination of high vacuum and cut rate, the entire lensectomy was done. So this is a new single piece hydrophilic CMT Flex IOL. As you can see, it's a single piece lens and it has got these specialized T-shaped haptics. So basically these T-shaped haptics, when you pull it out of the sclerostomy, it opens up and then stays in position, so there is no need for suturing or tucking. So this can be loaded into any of the normal IOL cartridges, but just make sure that the T haptic comes out first, and it can be done through a clear corneal incision. So we also have 2 specially designed forceps, the T-Flex forceps, as you can see here, just having a broad tip in the center. It should not be sharp, because if it is sharp, being the hydrophilic material, it can bite into the material. So as you can see here, we are holding the neck part, or you can hold the head part of it. At this moment, we should not pull it out, because it's again a single piece, so it can detach. So first have a clean hold and then inject the remaining of the lens. So then you can leave the trailing haptic either in the wound or above the iris, and then slowly pull it out. At the sclerostomy, you will see a small tug when it comes out, and then when it pops out, the T opens up, as you can see there. So because of the design specification, so you don't have to do anything else, and it just sits in place. So just a small animation clip. As I said, make sure that the T comes out first. So when you load it, I just make sure it goes into the cartridge, the T-shaped haptics. And then through the clear corneal incision, whether you have an old incision or if it's a large incision, you can always make just a clear corneal incision in opposite end also. So grab the head or the neck part of it. Once the remaining of the lens is injected, and then gently pull it out. So you'll see the pop-up and the opening of the T. For the other side, we use the handshake technique. So we have the second forceps called the Nishi grasping forceps. Basically, it's got serrations. So again, just to have a nice hold and a grip. At the same time, it should not damage the IOL. So just exchange it to the other hand. And being hydrophilic, it is very tissue forgiving. So when you're doing all these maneuvers, or when you're combining it with other procedures. So once that is out, as long as you have the 0-180 degrees, there will not be any tilt or any astigmatism caused because of the lens. And we also have an angulation between the optic and the haptic. So this angulation is what prevents any rubbing of the iris or pigment dispersion. So you get nice round pupils and good dilatation. So you can actually, at the end of the surgery, glue the flaps, or you can actually suture it, or you can even cauterize it. So these are some of the immediate post-operative pictures, and this is the 1-month pictures. So we almost have more than a 5-year follow-up now. So we have done a lot of studies on UBM just to show the position of the lens, and also the OCT images of the sclera, just to see on long term how the scleral flap bed is and how the lens haptic, is there going to be any long-term erosions, isn't it? So moving on, we also have a lot of publications now recently out on the various journals. So my main intention here is, now people are doing the lens, so I thought I'll just share a few tips and tricks about doing the CMT Flex IOL. So the sclerostomy that is made, initially I used to make with the needle, the 23 gauge needle, but then I found sometimes I used to get stuck, so I used to extend the section. So nowadays I prefer the MVR blade, basically because it's got 2 sharp ends, so you get a better, cleaner cut. The second thing is I started making the incision perpendicular to the limbus. So initially we were making it parallel. So I'll just show you a picture why, how, and this has helped. So when you make the incision perpendicular to the limbus, because of the T-shaped haptics, when you do the other side, the chances of it coming in is less. So initially we were making it parallel to the limbus, and the T also aligns in the same way. So through my colleagues and friends who gave me the idea, then when you make it perpendicular, you have better strength and less chance of it coming when you pull the other side. The second thing is we have given an angulation, so there's a hole on the right top side, so that gives you the indication, as you can see, the bend of the lens, because that is mainly given so that there is no rubbing of the iris. So, and the dialing hole can actually show you like which side it's coming out. So even if the lens tilts, you know exactly how to align it. So that is the another thing that you can see, that concave curve that is there, the 10-degree angulation. So initially it was like 7 degrees, and then the later thing. The third tip is to hold it head on. As you can see, this position is called the head on position. We found that is the easiest and the smoothest way to get it out. Basically, why? Because when you hold it head on, if you've seen the first video, I had the head, this is the head on. So when it comes out, the T bends inwards. So that way, when it comes out of the sclerostomy, it is much smoother and easier when it comes out. And also those dialing holes can be used, but some people told me they use the dialer when they do the handshake technique. So you can use this thing, or when sometimes it gets dislocated or is falling, you can also use the dialer hook to hold it so that you re-grasp the IOL. So again, as you can see here, for the second side, just holding it and removing it outside. So yes, complications are there as you have in any secondary IOL procedure. So this was one of the initial cases where I used to, as I said, the sclerostomy I used to extend with the thing. So one common thing is when you pull out the other side can slip in. It is not because of the design or the length. It is only when your sclerostomy is more. So various ways of managing it. As you can see, that's a large sclerostomy there. So various ways of managing it. One, you can do the same sclerostomy and actually suture it, like how you do a sclerostomy suture for the retina, this thing. So you can actually suture those haptics. But here what we did is we went slightly anterior, just 23 gauge, and then use the 23 gauge forceps again. So re-grasped it and brought it out. So some people are doing the modifications, and now they're usually doing the Hoffman's pocket also. So what the advantage of the Hoffman's pocket is, actually this T actually sits under the scleral flap, and you don't have to expose the scleral flap like this. As you can see here, the old sclerostomy is back, so it just stays here. Late dislocations in our study as a case series we have not had after implantation. It is only if there is any trauma, or if there is a haptic cup. There was an incident where we had used the ILM forceps, which is slightly sharper. So when you're using it, it slightly bites into the neck of the lens. So in those cases, that tip gets cut. So this was one particular thing post-trauma. So just to show you, like any other hydrophilic lens, a VR surgeon can easily remove it from the vitreous cavity. In this, since we had the chandelier, so I did not bring it out totally. So I exchanged it into the vitreous cavity itself, and then directly itself, I just brought it out of the sclerostomy. The other advantage is because we make the 23 gauge sclerostomies, so I used the same sclerostomy there. So at one moment, so I didn't have to explant the lens and then reintroduce it again. So as you can see here, just brought it from the retina and then brought it out. So it was because of the trauma. You can see the superior iridodialysis. So this is how at last we had to repair the wound and also do an SFT to get the shape of the iris. So these are just some small tips and tricks that we have learned in this 5-year journey from the time it was started in I think 2015. So as I said, some of the complications that are common for any secondary IOL procedures, and it was a long journey from All India release in Delhi, and then the COVID came. So there was a 2-year delay for us to come out, and then happy that many people are using it. So once again, thank you. Thank you, Dr. Cyrus and Dr. K.K. Mehta sir, for including me in this wonderful session. Thank you.
Thanks, Nivean. First, I saw a video. In fact, Ajay told me, Cyrus, how are you fixing secondary IOLs? I said, I'm doing this suturing and all. So it's all crap, yeah. See Nivean's new lens. So he sent me a video, and I saw Nivean's new lens, and I started putting in a few of them. And that's why I thought in our course he should come and give a talk about this. And now, Ajay wants to ask him a few questions. Ajay is professor of ophthalmology at Somaiya Medical College.
Yeah, Nivean, very good videos. What problem I have faced is that when I pull out the T, the T breaks.
Okay.
So that joint of the T, that it's that neck of the lens is quite weak, is what I feel. That's where you should try to get that a little different material or a little stronger.
At the neck part.
Yeah, because the T just detaches from the optic.
Okay.
And how did that lens fall down that you picked up that CMT flex from the retina? What happened exactly?
This was a patient we had done, and he had a trauma, a blunt trauma actually. So then he came that time. Yeah. So that time it was dislocated and it had fallen into the vitreous. There was no cut of the haptics.
Yeah, that's
so
what I
that's what
saw,
it was very
because
strange, isn't it?
So I
but
mean,
they
like,
had
like,
iris prolapse and everything.
No, there was really a hard blunt trauma to flex the whole globe.
Correct.
So you sort of detach those two T's and goes down. So you mean to say there's no fibrosis happening in the subscleral space with that T there?
No,
That's
in
what I was
our
asking.
long-term study, we have seen that it's very stable, isn't it? Like now, right now, the next publication is on 5-year follow-up.
Okay.
So there is fibrosis that happens under the scleral bed, and that is the reason why I'm telling nowadays we don't have to use glue.
Okay.
Because initially those 3-piece haptics are thin, and you might have leakage and hypertony, so then glue has a role. Here, glue doesn't have a role because the size is measured so that it fits into the sclerostomy. So nowadays, I'm just cauterizing the conjunctiva. That's it.
Overlying it.
That's
so
it.
you're not making any flaps now.
No, we're making the flap. The flap is essential so that the T haptics, because the acrylic material has to cover
Oh.
it. It can't be above that.
Can't we make a groove? I was saying you make a long groove so that like a half thickness groove where your T is going to stay in that groove. And then in the center of the groove you pass your MVR, like how you showed me, like a radial MVR. You're doing radial to the limbus. Yeah. That's the way we also do as retinal surgeons. We were taught. So you have more of limbus area virgin. So
Sure, sir. I'll wait for your videos next presentation
mine
with the
is little
modified
bit-
technique of the groove.